everyone hear now?
Thank you for joining me. Hi, let's start this again. Dr. McCoy. Um, I talked several minutes and rambled on just to realize that I had my sound turned off. So that's embarrassing. So we'll start over. Hi, I'm Dr. Travis McCoy of Piedmont Reproductive Endocrinology Group in Greenville, South Carolina, Asheville, North Carolina, Columbia, South Carolina. And tonight on our Facebook Live presentation, we wanted to address and discuss endometriosis. Endometriosis is a common disease. Wow, it seems like I've just spoke about this a minute ago. Endometriosis is a common disease that can affect 1 out of 9 to 1 out of 10 women in general. And this disease leads to primarily two things: pain and fertility problems. And they don't always have to lead to both of those. Sometimes it only presents as fertility. Sometimes it presents more as pain. This is a disease where the endometrial type cells, the cells that are normally growing inside the uterus, are actually living and growing outside the uterus. So endometriosis encompasses those cells growing outside the uterus. There is a type of this disease, kind of a cousin to it, for lack of better terms, called adenomyosis. Adenomyosis, we'll talk about later, is where these endometrial cells actually are growing up inside the uterus. So these cells are growing outside the uterus, and they can get there several different ways. There's several different theories and controversies about this. There's generally 4 to 5 pathways in which they can be present. In many cases, we think that they have been present from birth, with a couple different theories on etiologies, and that these cells get activated with puberty and start causing problems very early on. And this is really responsible for a lot of the early pain in young women. There's also some theories that over time these cells can just form as well. But in all of these cases and theories, the end point is very similar in the types of problems they cause. In this disease, it's a problem of these cells being able to live outside the uterus where they normally do not live, as well as a problem of the body's immune system not able to adequately fight off and kill these cells, which would normally happen in cells that are in the wrong place. So these cells, as they live outside the uterus, in a brief overview, is that when a woman has her menstrual cycle and her period, these cells, the cells that are inside the uterus, break down and bleed, and that blood comes out the uterus as their menstruation. These cells, on a microscopic basis, are breaking down and bleeding very microscopically. And blood inside the pelvis is a great source of inflammation and irritation. And when this inflammation and irritation occurs, the body's immune system tries to kill that off. That sets up an inflammation, just much as if you had a splinter in your hand and it gets red and swollen. That's generalized inflammation, part of the immune reaction. And if that irritates nerves, then your brain can sense that as pain. In other cases, it may not always irritate nerves. We think that some women have more nerves in certain areas than others, and that's why some women can have significant amounts of disease and very little pain, or vice versa. But this generalized inflammation that gets set up, the thoughts are that that relates to fertility by basically creating a harsh environment that can be toxic to both eggs and sperm. Some very early research studies done in the 70s and the 80s looked at taking a little bit of fluid from the pelvis in women that had endometriosis. And the chemicals that is in that inflammatory fluid was found to be toxic to both sperm and eggs. So we think that's the majority of the pathway in which infertility can occur. In some cases, the inflammation can lead to scar tissue, which can then cause a physical obstruction between the tubes and ovaries. And that physical obstruction can lead to fertility problems too. But it's probably primarily an inflammation issue. So this disease often presents very young. I usually say it's a young woman's disease. In most cases, it gets established in the teens and 20s. The typical let me go back. It's underdiagnosed tremendously. We know that the majority of women have a delay of diagnosis anywhere between 7 to 9 to 11 years before they're actually diagnosed with endometriosis after suffering. So many women have had the problem since their teens and 20s and aren't really truly diagnosed or treated until their late 20s. And that's really a shame. So there are several different reasons for that could be discussed. But endometriosis, the course clinically that we see is typically initially the women start to show that they have painful periods. But it's really hard to judge in a young girl what is painful, normal painful, and what is too painful. A young woman, when she starts having her periods, a lot of times it's hard. She's never seen that kind of pain before, and so the pain is always significant. And so it's hard to know, especially for parents, is this normal or is it too much? And sometimes in young women, you really have to look at whether it's affecting their daily activities. Are they having to miss school? Are they having to miss playing sports? Are they having to miss out on their activities? That's signs that it's starting to be a little too much. But over time, over a number of years, these symptoms can progress. The endometriosis sometimes progresses, doesn't always, but the symptoms usually progress to where they just have painful periods initially. Then over time, what we start to see next is usually the development of pain in the days leading up to the period. And I tell patients and other providers when I lecture on endometriosis that the one sign that seems to me in my practice that is just so uniform of endometriosis is that of having pain before the period. In a woman without problems, normally her period should not be painful until the day her period really starts. She should not have any pain until that day. Pain in the days leading up to it, even a day, but especially a couple days leading up to it, that is such a hallmark to me of endometriosis. And in my own personal experience, I found that sign alone is almost completely diagnostic of the presence of endometriosis. Often that over time expands to where they're hurting 3 or 4 or 5 days before their period. Then the next thing I usually see in that progression is that women can have pain around the time of ovulation. And many women say, I can tell when I'm ovulating. Well, some women may be able to feel when they're ovulating, but most women should not, and that really should not be uncomfortable or cause a discomfort. What often happens is that the ovulation process is normally a very easy, benign process. And when you release an egg, a small amount of fluid comes out of that, and normally that's very gentle. But in the pelvis, when the areas under the ovaries are inflamed and irritated, even a small stimulus that would normally be not painful can be picked up as significant pain. And so a lot of women start to feel their ovulation more and more each month. And in some cases, they can also progress to having pain with intercourse. And not every woman has that. Some women can have severe disease and not have pain with intercourse, but often that can be the cause. Some women do have pain or uncomfortableness with intercourse and have always had that, but a new onset pain with intercourse when she used to not have pain and now she does, that is always a big red flag and a concern for the disease. In other women, it can cause other symptoms, pain with exercise, pain with exertion. It can also, in some women, cause a chronic low back pain. Many times the brain confuses where the pain is coming from, and pain in the pelvis, those nerves run into the back, and so the body gets confused and interprets it as low back pain. Some women can have symptoms of recurrent urinary tract infections. Endometriosis and inflammation that inflames the bladder can cause problems with having to go to the bathroom frequently, pain with emptying, and so a lot of times that can be the problem. And they can also have pain with bowel movements. Those are the most common symptoms pain-wise that we see in women. But again, as I said, not every woman has pain. I've seen some horrendous cases that even in hindsight, knowing how bad it was, she swears she didn't really have pain. And other women can have very minute amount of endometriosis and have pain that's nearly fully disabling to them. So that part is very unpredictable and not directly related. In many women, it can present just as fertility as well. Going back to the progression, though, that line I laid out is the normal, usual, typical progression. As far as the actual disease in the pelvis, some women can have mild amounts where they have very tiny microscopic areas that are growing on the lining inside the pelvis called the peritoneum. And other women can have disease that gets more irritated and inflamed and actually grows under this peritoneum and can start to grow around other organs involving the intestines, the ovaries, the tubes, the uterus. And that's a much different animal in how it behaves. There's a lot of evidence, though, that mild cases of endometriosis do not progress to severe cases. And in many cases, the women who have severe disease have had that from an early stage. Now, obviously, they didn't start out as severe, but generally women that are severe from their early 20s, 22, 23. And if she hasn't reached the severe stage by her late 20s, she probably never will. In women, sometimes, especially as they age and get into the 30s, we can have problems with what's called adenomyosis. This adenomyosis is kind of a cousin to endometriosis, and there's a strong correlation in their presence. Adenomyosis, where the cells are living inside the wall of the uterus. This occurs, and their biggest risk factors are women as they get older, especially in their 30s. It's pretty uncommon to see it before 30s, but sometimes you can. And in women who've had some type of pregnancies or procedures on the uterus that disrupt the separating layer between the endometrium and the myometrium. And adenomyosis typically can cause more painful periods. Doesn't so much cause pain outside the periods, but it can in more advanced stages. Sometimes it can cause heavier periods as well, where normally endometriosis does not interfere with the nature of the cycles or the heaviness. But in all these instances, when you look at it from a pain mechanism, we look at how to manage those patients. As we mentioned, fertility commonly has problems with the presence of endometriosis. It is hard to predict exactly when I see a patient that has a surgery for pain reasons, and she asks me, am I going to have trouble getting pregnant? The answer is, I'm not sure. Until you start trying, it's really hard to predict. However, in more advanced stages, what we term stages 3 and 4, those patients will uniformly have difficulty getting pregnant. Though even then, some of them may be able to conceive once they start trying. But with fertility, often many women, endometriosis can be silent or just under-recognized. Sometimes women are not really good at, not women in general, but patients that have pain are not really good at describing their symptoms. And so sometimes I really have to press patients to get out some of these red flag symptoms. Most women do not come in saying, I have pain here, here, and here. And more often than not, I see women trying to underplay their pain. And when I get the questions out on how much this pain is interfering with them, it's a natural tendency, I think, to downplay it. And so sometimes getting that message across to your doctor helps to raise some of those red flags. But with fertility, many times it simply shows up as difficulty getting pregnant, often termed the quote-unquote unexplained infertility. Unexplained infertility is a case in which there's no defined problem. The tubes are okay, the sperm look okay, and she's ovulating. That kind of falls into the unexplained category. In the older days, we used to perform a laparoscopy on these women to assess if there was endometriosis, and I think that's not a bad idea at all, except that when we take into account insurance and other costs, that may not always change the plan and what we do. But some studies have shown that in women who have unexplained infertility that have been trying for more than 2 years, you will find endometriosis in 50 to upwards of 60 to even 70% of those patients. Those same women who are also hurting have endometriosis in over 90% of them. The treatment of that fertility-wise we'll talk about, but many times it presents as unexplained infertility. Often I'll see it as unexplained secondary infertility, where the woman may have had a child when she was in her early 20s, but is having trouble now getting pregnant in her late 20s, early 30s. And time changes a little bit, but the one other thing that can progress is that she got pregnant when she was very, very young and super fertile, even despite a little bit of endometriosis. But over time, that endometriosis progression with the added effect of age can really cause some trouble getting pregnant again a second time around. And so that's one of the things we always think about. So when it comes to management of endometriosis, a lot of what we do depends on her goals. Is this just a pain issue, or is it a fertility issue alone, or is it a combination of both? And I see all of those cases. Many women I see have tried multiple therapies, and often unsuccessfully. When we look at just pain, we'll start with pain first, and then we'll get into fertility. Women who have pain and are not trying to conceive, the management of endometriosis generally falls into what we term the medical and the surgical management. The medical management is aimed at treating the symptoms of endometriosis, the pain, painful periods, and pain other times. Medical management does not help the actual disease. It does not stop the growth and the presence of the disease. It just tries to calm it down, to quell that inflammation, and thereby reduce the pain. There are different ways of medical management. All of them revolve, initially, the majority of the treatments revolve around the use of what's called progestins. Progestins is a progesterone type compound that actually is counteractive to the endometriosis cells. It limits their development and their proliferation. And the thought is in doing that, that reduces the inflammation with the hope that the body's immune system can slowly start to get caught up. The progestins are often administered as a birth control pill. That's often a first line that many people get put on. And that's really a fine line, though there's some theory, you can talk theory about there may be other better options, but just a lot of general gynecologists don't use. But all the progestins usually give a similar effectiveness. There's some theoretical differences between them, but all pills accomplish the same thing. And studies have shown that you can get a significant reduction in pain with periods, pain outside of the periods, with birth control pills in upwards of 70% of women or more, 70 to 85% of women. But there is about 15% of women who will not really adequately respond. There are other medical treatment methods in those. One is what's called a Gnrh agonist, most commonly in the United States known as Lupron. Lupron is given for a lot of doctors for different reasons, and it takes a different mechanism of action by trying to lower the estrogen in the body to counteract the growth, and that can be effective. But if not used effectively and in the right way, it can have some symptoms and side effects to it as well. And it's not a long-term treatment. It has some time constraint limitations on how long we can use that in a patient, normally only limited to a couple years, and then you have to come off of it. With each of these therapies, studies have shown that generally you start to have a return of symptoms when you stop the treatments. Generally by 6 months, about half the effect is gone. By a year, nearly all of the effect of the medication is gone, and they've gone back to baseline. Medical therapy is often started, though, and it's first line because it's easier and it's simpler. And in some women, it can be very effective. There are some women that you can put them on a birth control pill and they're magically better and all of their pain is fine, and they will never have any problems for years. But other women, either it only slightly controls their symptoms and it doesn't fully control it, or it works for a while and then they start to have a progression of the disease. In some women, endometriosis can progress despite medical therapy use. And in those women is when we usually turn to surgical management. Surgical management is something I kind of specialize in with more difficult cases of endometriosis, and it was kind of a learned skill over the years of having patients that were difficult and were undertreated. Because endometriosis sets in the pelvis, it often sets around some vital structures, the ovaries, the tubes, And often it lands on the surface of covering what's called the ureters, which are the tubes that go from the kidneys down to the bladder. And those are very critical structures. If you injure them, that can be very bad. And general gynecologists don't get a lot of training in endometriosis. I trained at a very good university that had an advanced surgery fellowship, one of the first in the country. We got excellent surgical training, way above average, and my surgical training in endometriosis was poor. Um, Most of everything I learned, I self learned over years out in private practice. And so, general gynecologists who aren't used to doing these advanced surgeries vastly undertreat endometriosis. I see that all the time. Now, but there's variable response. Some women you can go in and destroy the cells a little bit, and they'll get good response. But many times that's not enough. The mainstay treatment is what's called excision, where you actually go in and you cut out the endometriosis. Most of the endometriosis is initially growing in this peritoneal layer, and you cut that out, peel that off. In some cases, in deeper endometriosis, it can grow around the veins, the arteries, the ureter, and you have to dissect that out. It can behave much like a cancer can down there, and it can be difficult to get out. And so that is the mainstay of treatment. Many people were taught to use what we call ablative techniques, where you try to burn it. But the problem is you cannot judge adequately if you've destroyed all the disease at that point. And so many people, they're destroying a small amount of it. And that's why patients get relief for a short term, 6 months or a year. But they've been really just treating the tip of the iceberg and haven't got the deep disease. Often pain with intercourse can be a sign, and pain with bowel movements can be a sign of very deep disease. And that can be very difficult, and it's grossly undertreated. Endometriosis can also involve the ovaries, and over time that can damage the ovaries and start to destroy them. And it's really catchy and touchy about treating the ovaries, because you want to take the disease out, but if you're too aggressive in taking it out, you're also destroying the ovaries and her chances of future fertility. And unfortunately, I see patients all the time that their other doctors, their general gynecologists, were over aggressive, either taking out ovaries, which in my opinion almost never needs to be done, or were overly aggressive in taking out a lot of the disease, and they've destroyed the ovaries in the process. And they've now dictated these young women to having to go serious other routes, often having to use an egg donor. So endometriosis, if they fail medical management, we often go to surgical management, and sometimes that can be very simple, and but sometimes it can be quite complex. A lot of the surgeries I get are repeat surgeries, or people that have horrible disease, where I would actually prefer their doctor look in, see how bad it is, and just get out, because they're not accomplishing anything, and let me have her and have a good first line treatment. With good surgical excision of endometriosis, with a complete excision, I expect a tremendous improvement in their pelvic pain with their periods, and I expect all the pain outside of her periods to be gone. Pain before the periods, pain with intercourse, pain around the time of ovulation should be gone. Now, you can't always guarantee that, but I can guarantee that the pain outside of their periods, the vast majority of it, probably 95+%, will be gone, and their periods will be tremendously better. They can still have problems down the road, and so the mainstay therapy, even after surgery, is suppressing them hormonally long term anytime they're not trying to get pregnant. Some of these diseases, some of these cases can be very difficult. The disease can involve the intestines, involve the rectum, the appendix. Those need to be taken out. It needs to be cut out of the intestines. In rare cases, take out a portion of the intestines. But in almost all cases with severe endometriosis, the uterus can be spared and the ovaries can be spared in nearly all cases, in a young woman who wishes that. Good studies show that if you take out all of the disease, you can leave the ovaries behind, and in the vast majority of the time leave the uterus behind, and she will get extremely good pain relief. The catch to that is, I tell patients that often down the road they may have trouble with their uterus. The uterus can often betray women, especially as they get older. And a lot of the problems they have is related to this adenomyosis. I can take out all the endometriosis outside the uterus. However, some of these cells that are inside, I can't address those. You can't take them out. And if the uterus is really the source of pain, which in some women it can be, the only option is to remove the uterus through a hysterectomy. But even in those cases, almost never, 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 never do the ovaries need to be removed. You can leave the ovaries behind, give hormonal function, and rarely have a recurrence of disease. So if a person is, if their doctor tells them they need to have a hysterectomy and have the ovaries removed, you need to stop. You need to get another opinion because that's not the treatment course. There are sometimes I have patients I have to resort to a hysterectomy eventually, but generally they need to have a real thorough surgery initially and they can kick that way down the road, hopefully until the time is that they're done having children. Then that decision is much, much easier. Unfortunately, there is a small percentage of women that I have. I have a half dozen at any time that are very young in their 20s that have a severe problem with their uterus. And the only real permanent treatment they're going to get is a hysterectomy. And we're trying to fight it tooth and nail. And those can be very difficult cases. But almost never does the uterus have to be removed in the vast majority of women. And almost never do the ovaries have to be removed. That's not part of the treatment course surgically. So with pain, that can be managed surgically, and though most people will start with medical management. When it comes to fertility, medical management generally includes a birth control pill or progestin suppression, both of which serve as birth control. So obviously, if you're doing that, you're not going to be able to get pregnant. Medical treatment, however, it's well known that it does not change fertility outcomes. So going on a birth control pill or other medical treatment for 6 months or a year and then trying to get pregnant does nothing but waste time. And it does not change fertility. When it comes to fertility, a lot of, even if I suspect endometriosis, when a woman starts trying, the first thing is to do is start trying. Make sure there's nothing else going on. Make sure you're not missing a male component, which I spoke about a few weeks ago. Go back and check the Facebook Live post. And then, if they have no other targets of identifiable problems, it may be an endometriosis component. As I mentioned, women that have been trying more than a few years with no other explained factor, often endometriosis can be present in up to 2/3 of those women. In women who've been trying more than 3 years and have not been successful, their per month chance of getting pregnant is usually where a normal pregnancy rate, say early 30s, might be 20 to 25% per month. Their per month chance may be as low as 1 to 2 to 3%. That's really low, but it makes sense because if it was really higher than 2 to 3%, she probably would have been pregnant in the next couple years. In those women, the mainstay treatments for fertility are either manage it surgically. The catch to that is I tell women that a laparoscopy, where we go in with cameras and treat the endometriosis, cutting it out, it helps fertility some. But the key word is some. You can definitely improve their fertility, but you can never get them anywhere near close to their normal conception rates. The other treatment is that if they're ultimately not able to conceive, bypassing that through things like in vitro fertilization, which resolves the majority of endometriosis cases, especially mild to moderate endometriosis. IVF, though, is a much bigger step for many women, and it really depends on their patients, how long they've been trying. That may be the better option. In evidence of severe disease, of bad scar tissue inside, IVF may be necessary regardless, and so she might be better off going straight to IVF. For some women, surgery can be an option. Surgery is a more straightforward option if the woman is both having pain as well as having fertility issues. In those instances, she may get the benefit of pain relief. I see several patients who aren't even able to have intercourse due to pain and can't even try. Very clear, we need to fix them up, help that pain so we can actually even start trying. And that gives some better ideas when we see the severity of the disease as to what their odds are after that. The thought process with surgery and endometriosis is that it's a debulking surgery where you're removing the endometriosis, and that helps to reduce the inflammation, and which then can raise the success rate. And depending on several factors, her age, has she been pregnant before, the status of the tubes and ovaries, you can raise her per month pregnancy rate upwards to between 8 to 10%, 6 to 10%. depending on those factors. That's a lot better than 1 to 2%, but it's still nowhere near 20% where she should be. What most women need after surgery is time in trying, because her per month chance is still low, but it's a lot better. So she needs to try a while. Some of the older treatment therapies were that if they have endometriosis afterwards, we would cut the standard of care. When I was coming through training was you would give her ovulation induction medicine with inseminations. But a good study published a couple years ago show that that's really not effective. It's not any better than trying on their own, as long as she ovulates normally. If they don't ovulate, that can be a separate issue, and we may use those medicines. But in a woman who ovulates regularly and the sperm's okay, I would let them just try on their own, because our medical treatments don't improve the success rate at the end of 1 year. The couples who did ovulation and medicine with inseminations versus the couples that tried on their own had exactly the same success rate. However, patience is a real limiting factor. Patience is a hard game. By the time women come to me, they were all ready to usually be pregnant last month. They've generally been trying a couple years, and their patience is starting to wear thin. In some of those women, that's why the quicker treatment may be to go straight to IVF. But if they have patience, then a surgical treatment may be worth it. More so if they're having pain, and I think it's a real clear benefit. But in those cases, I tell couples that I want them to at least give it a try of 6 months, if not very reasonable to try upwards of a year afterwards, to really be able to appreciate the benefits of the surgery we just went through. Because if I do surgery for fertility purposes, and she turns around in 2 months and wants to do IVF, well, the surgery doesn't really change the outcome of the IVF, so she could have just went straight to IVF and we didn't need to do the surgery. Though the surgery is straightforward and outpatient and very low risk, it is a surgical procedure and it has some risk involved with it. So if we're not gaining anything, don't do it. But if women try and are conservative, they can have a fair chance of getting pregnant. I'm going to show a slide in just a minute of one of the tools I use afterwards is something called an Endometriosis Fertility Index, an EFI score. This is a scoring system we used, which was created by a person in our field. It was basically one of his life works of trying to estimate what a woman's chances are of getting pregnant after surgical treatment for endometriosis. And it takes into account several factors, whether the tubes are normal, whether the ovaries are normal, her age, if she's ever been pregnant before. And it helps to give this what we call an EFI score. That score ranges between 0 and 10, 10 being the highest. I've never seen a patient with 10. Probably can't really happen. 0, very severe. And with that, it tries to give a good estimate that I show patients of here's your chance if you try for a year versus even longer. And what we see, I'm going to go on over to this slide. I don't have a pointer here, but in the top graph, you can see that this shows the chances, the percent of women that are pregnant based on this score. The bottom line is 0 to 3, then the next line up is 4, 5, 6, 7 to 8, and then 9 to 10. And on the bottom axis, there's the number of months. So you can see that basically the higher the score, the significantly better chance of conceiving. The bottom table is simply a table form that looks at these numbers. So basically, the majority of young women that I would see that have a mild to moderate endometriosis may have an EFI score of somewhere in the 4, 5, 6 range, 5 and 6 typically. So a level of 5 gives a 1-year pregnancy rate of 23%, which you say that's not very good at a year. Normally a woman trying in a year's time, I would expect 90% success rate, but untreated, her year-long success rate might be 5%. So 23% is much better, whereas if the score is a little higher, 6 or 7, it can be upwards, of over 30%. At 2 years, that mostly peaks and plateaus out. With a score of 5, it's about a 40% success rate. So, very decent success rates, but that's a long time to try for 2 years. An EFI score of 7 gives nearly a 60% success rate. But what we see is really those curves in that graph really start to plateau off at about a year and a half. So by a year and a half, if a woman is not getting pregnant, her odds of getting pregnant the next year after that are not much improved. So I think it's reasonable to try 6 months to a year, even a year and a half on her own. But if she's not pregnant by then, she really needs to move on to IVF. The key factor for most women is patience. Many women say, I'm patient after surgery. And I had one of these last week that we did surgery. She said, sure, I'm going to try for 6 months. 2 months into the process, it was just really bothering her. And she didn't want to try anymore and was going to IVF. And that's fine. That's fine. But if patients can try, it can give them a reasonable chance at getting pregnant. But the longer they're out, like I said, by a year and a half, their rates have pretty much peaked, and the number that will get pregnant after that is very slim. So IVF is the mainstay fallback in women with endometriosis who are not able to get pregnant adequately, normally after surgery. Surgery plays a role. It's not always included in our workup and evaluation. You have to take into account many factors. You have to take into account insurance deductibles. I had one patient that had obvious significant endometriosis disease on ultrasound, but she had one of these casualty deductibles of $10,000. And I told her, we are not, fertility-wise, are not going to get $10,000 worth of treatment and success from your surgery. And so you're better off going straight to IVF, which she did and had a baby. And I said, well, we'll address the endometriosis sometime down the road, maybe when you get a better insurance plan through work. Whereas other women, if they have a low deductible, $250, $500, pretty cheap, it may be worth it, or at least helpful to them as part of the diagnosis to look inside. That's the definitive way to check the tubes. And endometriosis is found in a large portion of those. When I take those women for surgery, my own personal experience is that in the ones that have some of those symptoms that I suspected endometriosis, particularly the pain before the periods, in the last 4 years I've been at this practice, I've had one laparoscopy that did not have any endometriosis in it. And so when you use those kind of factors, the rate of finding endometriosis is very high. And I have many women that do get pregnant, but not all of them. Some women will have difficulty and will never conceive. And I think a lot of that probably has to do with what their underlying fertility is. Some women can be very fertile, and it's just a conditional factor. But there are some women that have other issues. And their rates aren't, the success rate isn't as high if there's other factors involved. If she has a male factor on top of it, well, that really hurts the success rate. And so surgery may not be as beneficial for them. If we have to do inseminations for a male factor, then most of the time surgery just for the fertility and then coming back and doing a year of inseminations, I would never recommend that to anybody. They would spend as much as they did on IVF itself. And so you have to factor these things into play about whether a laparoscopy can be helpful. I would love to know what every one of my patients look like inside and know where we stand. But that's just not always feasible, and especially when it doesn't change what we're going to do, our treatment methods down the road. A laparoscopy doesn't always fall into it. Because I have some patients that say, I'm done trying. By the time they walk in my office, I have no patience, and I'm ready to go straight to IVF. That's fine, but I have other women that say, I will never ever do IVF for whatever reasons. And for those patients, then laparoscopy, I would do it sooner rather than later, because I would rather know where they stand and then say we're going to treat it and then see where it gets you. Though it may not always get you to the end point of getting pregnant, and IVF might still be a fallback, unfortunately. So that's kind of how we judge the workup for fertility. IVF does bypass the majority of it, though there is some evidence that in women that have severe endometriosis, treating it surgically prior to IVF may help them. It's kind of in select cases, not in everyone though, and so it's a little unclear exactly on that. Some women, if they have significant what's called endometriomas, which are collections of endometriosis in the ovary, they may benefit from surgery before IVF, some may not. Some of it depends on their amount of their ovary function. Some women, across the board, women with endometriosis can have a little bit lower ovarian function and ovarian reserve. And in some of those women, if you go in and address the ovaries, you may actually hurt them more than you're helping them. Whereas if she has a very high ovary function, then the ovaries can withstand more surgery. I've had some cases that I went in to take out the endometriosis, but actually did not touch the ovaries the disease that's in the ovaries just because she did not have very much function to begin with, and I couldn't sacrifice any. And I said, I would rather you at least get your time to attempt conceptions and then come back and readdress the endometriosis in the ovary down the road. So that's a lot of rambling about endometriosis. I mainly wanted to cover some of those and hopefully maybe get some questions that will take us in other directions. Endometriosis is a bad disease. It affects a large portion of women. It can have a genetic family tendency as well. Studies have shown that in women who have a first-degree relative of a parent or a sister with endometriosis, they are at a 6 times higher risk of having endometriosis. So that comes into play. Not every woman that has bad endometriosis has a family history, but if she says, my mom had endo, my sister has endo, I'm much more concerned about her, even if maybe she's not having significant symptoms. But, a lot of times I really have to push a lot of women. I have a lot of times their partner comes with them. And the women, I'm trying to get out of them how bad are their periods. And they say, well, it's kind of painful. And the partner just looks at me and is like, what? You are on the floor rolling, crying, when your period's here and you can't work for 2 days. And so sometimes we don't always get the full kind of story. And you really have to give targeted questions and spend a lot of time with the patients in order to get out some of this fine tuning. And I enjoy endometriosis. I enjoy the difficult surgeries I do. I often do the surgeries that no one else wants to touch. And I enjoy that benefit, the treatment of those patients, because they can get a lot of benefit. And that's one of the most rewarding things I think that I do. I love my fertility patients. I do love surgery because I love the benefit that the surgery gives my patients more than the surgery itself. And I love the complex cases. But with each patient, they have to really figure out what their goals are. I do have some women that at a younger age are completely sure they never want to have a child. And then that may change what we do surgically. Rather than trying to preserve the uterus at all cost, they may be willing to give it up. And sometimes that might be a simpler solution. But a straight hysterectomy alone is, if you leave the disease behind, is never a full treatment. I often get women that come to me. I did 2 last week or week before last that had bad endometriosis. They had a hysterectomy. The doctors took out the uterus and left all the endometriosis there. And I had to now go back and reoperate on them, which is a horribly difficult case to retake out what wasn't done properly in the first place. So that being said, in the time we're going to start maybe taking some questions. I think my lovely assistants here have some questions.
We do. One was how is endometriosis different from uterine fibroids?
Endometriosis and uterine fibroids are very different and completely unrelated and no relationship to them. Uterine fibroids are a benign tumor of the uterus, and maybe I'll do a Facebook Live on that coming up. That's another field of mine. And that is unrelated. And so endometriosis is where the cells of the uterus are growing outside the uterus. So they are not related. It's not uncommon just because of the frequency of fibroids and endometriosis to see a woman have both of them, but there's not really an association between the two.
Okay, and then another was how long would I be out of work if I was doing surgery?
Recovery for surgeries, it does depend on the severity of it. If I have a woman that I really suspect that she may not have severe stage disease, a more standard simple laparoscopy with a couple incision sites, generally a woman is down a couple days. Pain tolerance is always better if they've had other surgeries, or especially if they've had children and as they get older. And so a simple laparoscopy, a person's down to probably can go back to work by 3 days. I'll often do some on Friday, probably go back to work Monday or Tuesday. A more severe case where they've been operated on before and I have to reoperate with those are done with the assistance of the Da Vinci robotic system. More in-depth cases sometimes can take 3 hours or more. And it takes more incisions. And generally you're very sore in your abs. I tell the women that have that kind of surgery that when they wake up, though they'll feel the pain of the surgery, they will usually feel that pain that they were having, I expect it to be gone almost immediately. But generally, recovery off of work depends on what their work requires. If they're doing desk work, sitting down, they don't have to be on their feet a lot, generally 7 to 10 days. If they're doing more activity, say a nurse that's up and down, probably at least 2 weeks. If they're doing on their feet all the time, like factory assembly line, can't take a break, can't pause, 12-hour shifts, maybe a full 3 weeks to get her full energy levels back for that. But a lot of it does depend on her individual pain tolerance. Generally speaking, the more you've had done and the older you get, the better tolerance we have.
Okay, so another one was, a lot of people are asking about tubal blockages. So is endometriosis the main reason for tubal blockage?
No, not at all. The question was about tubal blockages, and is endometriosis the main reason for tubal blockages? The majority of endometriosis tends to spare the tubes. Now, in severe cases, the tubes can get involved, and possibly it may be damaged and have to be removed. Sometimes a tube is an innocent bystander getting scarred up under the ovary and can get damaged, but endo tends to spare the tubes. And in those patients that usually have tubal involvement, they have other signs of disease. The uterus is stuck to the intestines. The ovaries are stuck to the uterus. So that's often picked up at the time of ultrasound, though I don't always know. I caution patients when I get there, the tubes are the one thing I don't really know about, and you may find problems you didn't know you had. Most tubal damage is generally post-infection, where a woman has had an infectious disease that she never knew she had, and that damages the tubes.
Okay, do you want to do like one more maybe?
Sure, a couple more.
Okay,
Shoot.
So you did talk about this a little bit, but people are talking about the different stages. So does endometriosis come in stages? Because I know you were talking about age and all that.
Sure. There is a staging classification that was developed back in the 70s. And the real purpose of the staging classification was just to let one doctor know to another roughly the severity of it. The staging itself is not super accurate, except to describe roughly ballpark who is worse than who. The staging doesn't tell you anything more than that. The staging takes into account scar tissue, whether it involves the ovaries or not. So there's actually a staging score that we have, but that really doesn't matter, especially as relates to fertility. It's been proven not to matter. But there is a staging system, generally 1, 2, 3, 4. 1 is considered minimal disease. That's a very small amount, maybe just one little area the size of my fingernail. Stage 2 is a mild disease. Most of the people who probably have symptoms are stage 2. It's very common to have an incidental finding of minimal disease, stage 1. Stage 3, most of the time by stage 3 it's starting to involve the ovaries and more scar tissue. And stage 4 is generally severe involvement of the ovaries with tremendous scar tissue, often involving the intestines and the uterus, and those are the ugly ones, the stage 4. But even in stage 4s, I have what's one person's bad is not another person's bad. So I'll often get a bad endometriosis case, and there's my not that bad, and then the terrible bads, as far as stage 4 goes. But there is that rough staging system, but it doesn't really tell you a whole lot except just roughly about the amount of scar tissue that a person has is what relates to it more. But as far as fertility goes, it's hard to predict fertility. Stage 1 and 2, stage 3 and 4, the majority of those will have fertility problems.
Okay. One person says, currently watching the Facebook Live on Endo. I would like to know if he's ever heard of or treated endometriosis with using Endovam, Endovam.
That sounds like it may be a supplement. I'm not sure what that is. The problem with that, endometriosis, it has a genetic component. Studies have shown that there's no supplements you can take to treat it, to make it go away. Even the most aggressive medical therapy we have does not make it go away. It helps manage the symptoms, and you can manage the symptoms a lot with medical treatment, but you can't manage the disease. Is a disease that can only be removed by surgery. Not everyone has to have surgery. I'm not saying that, but that's the only way to actually remove the disease. Everything else is simply tiding the disease over to try to limit the symptoms from the disease. The goals can be the same. Some people will get symptom relief, but there's no medical treatment, nothing into dietary changes. There's always someone that wants to sell you something out there, but there's no dietary changes, no activity changes, no benefit of acupuncture, no supplements. None of that will actually change the disease, the course of the disease, or fertility in particular.
Okay. Can endo make tubes inflamed or swollen?
Absolutely, that's a given with more advanced stages. The tubes often do get very inflamed. A lot of times, if you take out the disease that takes out that inflammation, the tubes can often recover from that. And many times the tubes are very swollen and very ugly and angry looking. But once you treat the disease, take out all the bad endo, the tubes will usually go back to normal. But as far as, like I said, getting pregnant, unfortunately in those bad cases, people worry about the tubes. Oh my gosh, you had to take out a tube. Well, unfortunately, the situation isn't very good afterwards either, and so that doesn't really change the outcome, unfortunately.
And where do you normally operate? Someone asked.
Oh, I operate in many places. I operate personally here in both in Greenville, South Carolina, at Bon Secours St. Francis System, and in Asheville, North Carolina, at the Mission Hospital System. Those are the two I operate. I do go to Columbia from time to time, but for a couple different reasons, I don't operate down there yet. Kind of those two hospitals, I have my main go-to teams. I have my own surgical assist that I take with me, that travels with me, kind of knows me, knows my surgeries, and that's one of the reasons I have those two areas.
All right, I think we.
Surely we've had
Yeah.
more questions. I know that women and husbands have a lot of questions about endo. It's a bad disease, and there's nothing, there's nothing you can do. You've done in your past, unlike some things like tubal damage. There's nothing that endometriosis that you've done to make yourself have that, and you have to deal with it. And we have ways of dealing with it, both with pain and with fertility. Most people try to take a conservative approach, but for some women, that won't work for fertility. When it comes to pain, often if a woman has had prior surgeries that weren't successful or the pain come back, generally it's because it was not treated fully in the first place. That's the number one cause I see. And in those people, we can definitely help them try to find a solution to meet their goals. So, thank you very much. I hope you have a wonderful evening, and God bless you.